Alright guys, so today we will discuss about the primary acid base disorder. So the first thing that you need to do is when you take an arterial blood gas analysis, you need to look at the pH of the blood. If the pH of the blood is less than 7.35, you know that it is acidemia. If the pH of blood is greater than 7.45, you will know that it is alkalemia. So first of all, moving towards acidemia and what are its causes. So the acidemia can either be caused by a retention of PaCO2 into the blood, or because you are producing some other acid into the blood which is combining with the bicarbonate, and therefore the bicarbonate levels are getting lower. So first you check for the pH which was less than 7.35. The second thing that you will check for is going to be your bicarbonate level. If the bicarbonate level are less than 22 milliequivalents per liter with a normal PaCO2, you would know that it is metabolic acidosis. If, however, the bicarbonate levels were normal and the partial pressure of carbon dioxide in the blood was greater than 45, then you would know it was respiratory acidosis. So first of all, check for the pH, then for the bicarb and the PaCO2 levels. Second thing that you should do is, for example, if your pH comes above 7.45, you know that it is alkalemia, right? Emia is just referring to blood, like it is going to be the pH in the blood. So you have alkalemia. So how do you differentiate the two types of alkalemia? You again measure those two same variables, the PaCO2 and the bicarb. If you find that the bicarbonate is high, so the bicarbonate can become high only in metabolic alkalosis, right? And the PaCO2 becomes less than 35 in cases of hyperventilation. You blow off a lot of CO2, so it becomes less. So you get two types of alkalosis, metabolic alkalosis and respiratory alkalosis, and you differentiate them on the basis of the bicarb and PaCO2 levels. Now, for example, you had a patient who had a pH of less than 7.35, came to you and you checked for the bicarb, it was less than 22 milliequivalents per liter. Now you would expect the PaCO2 to be normal, right? You would expect the PaCO2 to be normal. However, if the patient comes with some compensation, then the PaCO2 would be lower than normal, because the metabolic acidosis is compensated by respiratory alkalosis, which means that the metabolic acidosis, you try to blow off the CO2 in order to balance the pH. So the patient, if the patient presents with acidemia and a low bicarb, you know it's metabolic acidosis, right? But if the PaCO2 was normal, then that would mean simple metabolic acidosis without any compensation. But if the PaCO2 was decreased, you would know that there is respiratory compensation for this. There has been respiratory compensation. So another thing about alkalemia is, like alkalosis is, so again that you had this bicarb level which was more, right? And the metabolic alkalosis sets in, but then the respiratory compensation sets in. So you were expecting that the pH was greater than 7.45, the bicarb was greater than 28, you knew it was metabolic alkalosis. You were expecting that the PaCO2 would be normal, but it was increased because you brought in the compensation by hypoventilating. So you need to be very clear about the values. If you do not find normal values for PaCO2, you know that it is, and the patient has come in a compensated state, and that is very important because the respiratory compensation always sets in earlier. It is a very rapid response compared to the renal compensation, which we are just going to see. So for example, patient presented with acidemia and you found that the patient had respiratory acidosis and not the metabolic, because the bicarb level was normal. The patient presented with increased PaCO2 increased 45 mmHg pressure of the PaCO2. You knew it was respiratory acidosis, but the bicarb was normal. So you knew that the patient was in an uncompensated state. Because the renal compensation takes time, therefore it is a delayed response, which means that it will take some days, like probably 2 to 3 days for the renal compensation to set in. So the patient presented with the respiratory acidosis and also had a raised bicarb. so you would know that the patient's renal compensation has begun already. And the same is for alkalemia. Like you knew that the patient came with respiratory alkalosis and the bicarb was also decreased, so you knew that the patient's compensation has set in. So it is very important for you to be able to distinguish between these, that what are the primary acid based disorders, acidemia, alkalemia, and what are the compensations. I'll give you an example. For example, a patient who like ascended to a high altitude level, and so there's low PO2, so you start to breathe a lot, you start to hyperventilate. When you hyperventilate, you go into respiratory alkalosis. So for the first few days the patient will present with respiratory alkalosis and normal bicarb, but after a few days the bicarb levels will decrease because the kidney will compensate for the respiratory alkalosis. So that is what you should look for in the values. And likewise, you have a patient with diabetic ketoacidosis and you check for the pH, it's less than 7.35, all right, and you check for the bicarb, it's less than 22, but the patient will also have cosmol respiration, which is going to be this hyperventilation because he's trying to blow off the acid, and therefore the patient will also have respiratory alkalosis. The patient will present with values of less than 7.35 pH, less than 22 millicoulomb per liter bicarb, and a less PaCO2 also. So you would know that it is a respiratory compensated metabolic acidosis, which is diabetic ketoacidosis. I really hope this helps.